All right, welcome everyone. And on this segment, we're going to be covering stroke, or what we refer to in medical terms as cerebral vascular accident. In short, you're going to hear this in the clinical setting as CVA. All right, so we're going to talk about the pathophysiology of stroke. Stroke is a big nursing concept when it comes to your NCLEX. So, very important for you to review this because there will be a lot of safety questions regarding stroke. Now, pathophysiology of stroke. As you can see here, we have two types of stroke. We have ischemic versus hemorrhagic stroke. The concepts are, they vary greatly in the cause versus what they would need as treatment, but the idea is the same. On ischemic stroke, there is a blood, air, or fat clot that lodges into one of the arteries that feed a section of your brain and causes cellular damage or, at the end, cellular death. Now, in the case of a hemorrhagic stroke, there is an aneurysm or a burst in a blood vessel that causes lack of blood flow or lack of supply in a section of your brain, causing, again, cellular damage or death as well. All right, so this shows as a lack of oxygenation into that area. Now, ischemic stroke can be caused by anything, can be caused by thrombus, embolus, fat, air, amniotic fluid, embolus. A hemorrhagic stroke usually stems from a high blood pressure setting, causing that damage into that vessel and that burst. All right, let's talk about the risk factors. Very important to note that there's two types of risk factors, the modifiable versus the non-modifiable. Things we can change and things we cannot change. Now, what would be the problem here? NCLEX likes you to focus on the modifiable factors because these are things we can educate our patients on. Things such as hypertension, right? Hypertension causing that aneurysm. We got to lower that blood pressure. We got to make sure that blood pressure isn't above the norm. There's a couple different things here that will cause hypertension or those risk for stroke, but very important to note that there's things such as atherosclerosis or things such as high cholesterol, diabetes, obesity. One thing that people tend to forget is oral contraceptives, such as birth control pills. Smoking is a big concept there. I put these three things up here to remind you: smoking, drinking, drugs, right? Those are the big three lifestyle modifications we can change. Now, how do we diagnose stroke? We have one gold standard for diagnosing stroke, and that is your CT scan. When we find out that there's stroke, when we note stroke symptoms, we cannot initiate any type of treatment until we find out which stroke is which. Is it ischemic versus hemorrhagic? And the only way to distinguish that is by getting a CT scan. Very quick. That CT scan will show you left and right here, hemorrhagic versus ischemic stroke. You can see that area of the brain causing cellular death. Now, in an ischemic stroke, you can see that area of the brain that's lacking oxygen causing that dead tissue. Hemorrhagic stroke, on the other hand, most of the time when you get a CT scan of this in a clinical setting, you might not see that bleed right away. This bleed takes time. Now, are we not going to treat the stroke just because we don't see a bleed? No, we're going to treat it as stroke. We're going to treat it as stroke and treat it with the idea that this is a hemorrhagic type of stroke because we don't see that clot or dead tissue. So what are the symptoms? Okay, part of your BLS, you did learn the acronym FAST. Face, arms, speech, and time. These are the things that we will be teaching our patients, and these are one of the key symptoms you're going to be noting for your patient. Face means facial droop unilateral, meaning one side of the face is drooping. That can be your eyebrows, eyelid, cheek. When they smile, one side is lower than the other. Arm weakness, you can have them raise both their arms. One side is deviating from the other, causing that weakness. You can even have your patients squeeze both your fingers and one side is going to be a little bit weaker than the other. Speech, they're going to have a little bit of slurred speech. We refer to the speech part as aphasia. There's going to be different types of aphasia. There's going to be aphasia that's expressive versus receptive, and we're going to talk about that in just a little bit. Now, just to note, time is brain. The faster we intervene, the more brain tissue we can save. Now, other symptoms you're going to note down is symptoms are going to appear dependent on where that stroke is. Where did that damage happen? There's different areas of the brain controlling different motions, different senses, different capabilities of the body. Now, depending on where that damage is, that's where that deficiency is going to be. Now, as you can see here from this, let me go back. As you can see here from the hemorrhagic type of stroke, one key symptom we have here is going to be the increase in intracranial pressure. We talked about that pressure in the brain, right? We have three things in the brain. We have brain, blood, cerebrospinal fluid. When that blood vessel hits the burst and increases that blood volume in the brain, the other two components gets pushed back. That is what we call increase in intracranial pressure. Now, for intracranial pressure increase, there are some early and late symptoms. You do have to note down that those early signs, the headache, the vomiting, one key thing I always teach everyone is the number one sign of a neurological problem is always going to be altered level of consciousness. What does that mean? Confusion, irritability, that disorientation, that level of consciousness has changed, and that is your earliest sign. Now, know your Cushing's triad. When the increase in the intracranial pressure gets bad enough, one thing that could happen is, as you can see here on this picture on the left, that brain matter can push downwards. When that brain matter pushes downwards, that's called a herniation. There's no turning back from that. That is what we call clinically brain dead at that point. Now, we're trying to prevent that. We have to identify when it's heading that way. That is where the Cushing's triad comes in. We have three symptoms of a Cushing's triad that you need to note down. Hypertension or widening pulse pressure. What does that mean? The top number is getting higher, while the diastolic, the bottom number, is getting lower. So the systolic, let's say for example, 120 over 80. It becomes 130 over 70, 140 over 60, 150 over 50. You see that gap widening. Now, bradycardia is one. That brainstem right there, right below the brain, does control our vital center. Heart rate, respiratory rate. If that gets compressed, we do experience that bradycardia and that irregular respirations because we're pushing through that control center of breathing. You might note this as Cheyne-Stokes breathing, or that Cheyne-Stokes breathing is that period of hyperventilation with a period of apnea followed by another period of hyperventilation. And lastly, we can have a seizure. Seizures, when we increase that intracranial pressure, we put pressure all over the brain, we could misfire all those electrical pathways, and now we have a seizure. Now, stroke treatment. Very important again, find out what type of stroke because the treatment greatly varies between the two strokes. For the treatment of your ischemic stroke, we do have to bust that clot. That's our key word there. We have to burst that clot. What does that mean? We have to use what we call thrombolytics. What are thrombolytics? Anything that ends in an ACE, alteplase, streptokinase, reteplase, those are your thrombolytics. We also know it in the clinical setting as TPA. Very important to note that we must administer TPA within 3 to 4.5 hours of when the symptoms started. So if you note down your symptoms at 9 a.m., we have until 10, 11, 12, or up until 1:30, right? That 4.5 hours, that is our key there. Now, hemorrhagic stroke, we cannot let them bleed. You see how the treatment options greatly vary? If we give TPA to a hemorrhagic stroke, we can potentially kill this person because we will make them bleed even more, right? And if we somehow, for the hemorrhagic stroke, we need to implement lowering that blood pressure because the blood pressure is what caused it, right? Now, we can't just lower the blood pressure for ischemic stroke because we have such things as permissive hypertension, where we allow a higher blood pressure so we can bypass that clot and reach that area of the brain where nutrition isn't going into. All right, I listed a different, kind of more complete list of your medications that people receive during those stroke incidents. The TPA is our go-to in fixing that clot. After that, or with that TPA, we can give what we call anticoagulants and antiplatelets. Those don't burst the clot, but they prevent that clot from getting bigger. So what does that do? The antiplatelets, those are your aspirins, salicylates, right? Your heparin. Anticoagulants, those are your warfarin, your Coumadin. Blood pressure medication, we do have to use blood pressure medication for things such as hemorrhagic stroke so we can lower that blood pressure, causing less damage at that point. If one of your risk factors was cholesterol, let's give them a cholesterol medications. Cholesterol medications, your statins. We got to lower that cholesterol. That way we can lessen the chances of another fat clot forming and another fat clot lodging into those areas. So how do we manage our patients? I want you to think safety. When we discuss stroke in the NCLEX, they will focus on the biggest safety measures. So what do I want you to focus on? A, B, C, all right? Airway, breathing, circulation. You have an airway breathing problem instantaneously, and that is your dysphagia, meaning trouble swallowing. What happens then? With that facial drooping, one side is going to have a lot of trouble swallowing over the other. So don't feed your patient unless they have a gag reflex. That's key there. We got to have a suction at bedside. Make sure that if the patient does aspirate, we have something to intervene with. We do have to feed our patients with what? Thicker fluids, mechanically soft diet, soft or altered diets. And we, of course, we need to feed them on the unaffected side. Don't ever feed them on the affected side where the gag reflex is absent. If a clot was the first thing, right? If the stroke causes what we call immobility for your patients, there are now another risk for developing more clots, meaning DVTs, thromboembolitis, right? Thrombophlebitis, I mean. So what can we do? Range of motion. Move that patient. Make that patient mobilize as independently as possible. So one thing we can place them on is anti-embolism stockings. Now, we got to decrease that intracranial pressure. And how do we do that? Prevent any straining. Prevent anything that would raise that blood pressure. Coughing, straining in bowel movement, urinary retention. We got to intervene with all those things. Prevent blowing their nose, coughing. Make sure that head of bed is elevated so gravity is doing the work, sending all that volume down to the body instead. Okay? We don't want to suction that patient too much. That could increase that blood pressure as well. I got a different list here of diet modifications. Big thing is communication for those patients. So I'll let you guys read through this. Make sure you note this down. And then seizures. Note down what you need to do for a seizure. NCLEX loves asking about seizures. What do we do? What do we not do? Right? Know your seizure precautions. One big choice in the NCLEX is you never leave your patients alone during a seizure. Okay? Never leave your patients alone. We gotta never leave your patients alone. Turn the patient to the side. Loosen the clothing. Padded side rails. Right? Prevent injury. Safety, safety, safety. Nothing in the mouth. Don't never put anything in the mouth. If the seizure lasts for greater than 5 minutes, that's when we're concerned. That is what we now call status epilepticus. All right. Now, what do we not do? Don't force the jaw open. Don't place anything in the mouth. Don't leave the patient. Don't move the patient. Okay. So here's a little case study for you guys. Here's a little case study for you to do. Let's see if you can kind of figure this out. Take a pause on this video. See if you can treat your patient using the ADPI method: assessment, diagnosis, planning, intervention, and evaluation. See if you can figure this out. See if your answer matches mine. Now, you can pause this video at any time and you can move forward to the next slide to see if your answers are correct. And here's that answer to that ADPI process. This is what you need to be able to utilize to figure out, to be able to answer those NGN style questioning. All right. Now, here's a little recap between ischemic and hemorrhagic stroke. Again, that ischemic stroke is a clot. The hemorrhagic stroke is a busted blood vessel. We got to note down the symptoms, which usually are the same. Our diagnostic tool is a CT, but the treatment is where it matters the most. We got to differentiate between the two treatments, so don't disregard that.